I'd like to introduce Dr. Matt Butler. He's an academic clinical fellow and specialty trainee in psychiatry at the South London and Maudsley NHS Trust and the Institute of Psychiatry, Psychology and Neuroscience. He's currently doing a PhD investigating the effects of psilocybin on FMD symptoms and the brain, including neuroimaging in the SciFund study. Over to you, Matt.
Thank you, Vaughan. Thank you for the opportunity to present this talk. Like a previous speaker, I'm just recovering from a cold, so if my tone sounds excessively flat and nasal, it's not just because I'm from the north of England. So what do we know? So I'm going to present to you our mega-analysis of structural imaging in 493 patients with FND. So what do we know about the structural neuroimaging so far in FND? Well, very briefly, as this recent systematic review shows, there's been various regions that have been implicated in FND, including the frontal lobe, the motor cortex, and the sort of limbic cortex as well. But as you can see by the varying up and down arrows, the data is not entirely in agreement, and the studies are generally quite small. No offense to anyone who's done the studies, I know how hard it is to do a neuroimaging study. So there are probably avenues for using more big data approaches to kind of try and synthesize the literature, and that's exactly what happened through the project of one of our amazing postdocs, Dr. Miriam Vignando, who did a study in Parkinson's disease hallucinations, comparing structural neuroimaging and using this mega-analytic approach. So mega-analysis is a bit like a meta-analysis, but the key difference is that it analyzes the data on the kind of individual participant level rather than using aggregate data. So you could argue that it's, adds more power, it's a bit more granular, that sort of thing. So we wanted to do a similar thing to Miriam's project in FND, and so we put the feelers out to research groups internationally who'd done structural imaging in FND to see if they would be willing to contribute. And we're absolutely delighted that 15 research groups eventually agreed to contribute and sent over their data. And this is a relatively diverse international sample from California to Tokyo to Prague and sort of everywhere in between. And obviously I'd like to thank everyone who's contributed, particularly if they're in the room today. So how did we go about the analysis? So we asked the groups to send us their data from their previously sort of completed research studies. So this is all sort of in research contexts. And then we took all the data together and analyzed it in a program called FreeSurfer. If you don't know what this is, which I didn't 2 years ago, it's a kind of commonly used neuroimaging software. And we use it to extract morphometric values from structural data. So this included cortical surface area, cortical thickness, and subcortical volumes. And so what this program does is it sort of parcellates out the regions that sort of predefined using something called the Destriou atlas, and it gives you a sort of numerical value for the volume or the thickness or the surface area. And this is quite a successful process in our case. We had to discard a few scans, either because they weren't parcellating correctly for whatever reason or there was missing information, but the vast majority of the scans made it through. So then, because we're using data from multiple different sites, using different scanners, we wanted to try and reduce the variance that came from using different scanners. It's a sort of inescapable aspect of using different scanners. So we use something called the combat approach, which is a means of harmonizing the data to try and get rid of the variability which is associated with the site or the scanner, to try and just leave the data set in a state where you can analyze it as a single form. And Miriam had used that successfully in her Parkinson's disease project. And so then all that was left for me was to take out these Excel documents of loads and loads of numbers and run the analyses, which the initial analyses that we ran were sort of comparing our whole brain level between FND patients and controls. So the final sample consisted of 564 controls and 493 patients with FND. And this was either seizure or motor symptoms. They could have had other things, but if they didn't have these, they weren't included. And the sharp-eyed amongst you will notice that the subsamples of seizure and motor disorders don't quite add up to the total sample. That's because some patients did have both symptoms, not many. In that case, they were included in both of the subsample analyses. So what do we do to compare groups? So we started off with a combined data set that I mentioned, so one large Excel document for FND, one for controls, and then we ran it for a simple ANOVA. That's the kind of stats I was comfortable with. So we essentially didn't control for anything initially, so we just ran it for an ANOVA, which we then corrected using two means, the Bonferroni correction and the false discovery rate correction, because we were running about 250 tests. And these selected out regions of interest. So there were certain regions in all the three different sort of morphometrics which were significant. And then we then took those and reran them through a Mann-COVA, which is essentially an ANOVA with added in controls for age, sex, and total intracranial volume. And that again was Bonferroni corrected. And any of the regions that survived that Mann-COVA that was controlled were then deemed to be different between the groups. This is a kind of visual summary of the kind of initial data that we have, the initial results that we have from the data. So if you see the top left, this is comparison between FND and controls at a group level. We saw, on the whole, reduced cortical surface area in sort of disparate regions, but some which are quite exciting, including the bilateral subcallosal gyri, the olfactory sulci, the collateral sulci, and the post-central gyri, so some of the regions that have been implicated in other studies. Again, there was reduced cortical thickness in regions in the FND, for example, the paracentral gyri and sulci, the superior presentral sulci, and the superior frontal sulci. And the only region that showed any increase in FND was the bilateral pericallosal sulci. We found reduced volumes in subcortical regions, particularly the bilateral putamen and hippocampi. It is worth emphasizing that in each case across all these morphometrics, the differences are very small. So we're looking at partial eta squared values of less than 0.016 in every case. So an eta squared value of less than 0.01 is deemed to be, around 0.01 is deemed to be small. So these were kind of around the small to very small differences. So obviously the significance of those needs to be borne out. However, the data did seem robust. We, after we completed these analyses, we reran the tests again, excluding one group at a time to make sure it wasn't just a single site that was driving the changes. And actually the data held really well, so the results seemed to be consistent at sort of a grander level and weren't driven by one site. We then wanted to do a bit more kind of analysis about clinical variables, and I have to say this was a bit more challenging than we anticipated. There was lots of heterogeneity in the clinical information that was sent with the scans by the groups. Again, it was just differences in the way that the data were collected. So we weren't actually able to look at as many clinical variables as we would like to. However, we were able to build dichotomized variables for the antidepressant use, the presence of anxiety, and the presence of depression. And that was available for about 60% or just over 60% of the FND sample. So what we did then was we took the regions of interest that were significant post the initial ANOVA and reran them through a Mann-COVA, but this time splitting not by FND versus controls, but by, for example, depression plus and depression minus. And with depression, we did find that some of the morphometric changes that we saw in the overall cohort were different between those with depression and those without, so suggesting potentially there are overlapping etiologies or risk factors in depression and FND. That wasn't the case for anxiety, and it wasn't the case for antidepressant use. We also ran a partial correlation between the significant regions and the length of illness in years, so we were able to build a sort of variable for that as well, but there were no significant correlations between the values and length of illness. This is a really busy slide, but I think it can be summarized in a couple of headlines, which is that the motor subtype seemed to drive the majority of the differences in the whole group. So whether or not that's because there was a larger sample or whether or not it's something to do with the symptoms, we're not sure. But particularly the subcortical volumes seem to be significantly different in the motor group, which they weren't really in the seizure group. And I think the particular sort of standout for the seizure group is it was those patients that were driving the increases in the bilateral pericallosal thickness, so suggesting there may be differences in the etiology there, potentially. It's sort of in summary, so this is the largest structural neuroimaging analysis in FND to date, to our knowledge, and we did find that FND was associated with small changes in structural morphometrics. There was reduced thickness in some regions that have been previously identified by the reviews, including frontal and motor regions. So is that an effect of the reduced motor function, potentially? There was an increased thickness in the pericallosal sulci and its relationship to the limbic system, so whether this sort of maybe points towards an effective contribution to symptoms, particularly the seizure group. I think, obviously this is just the first step. Further research needs to really test the potential etiological significance of these findings. Are they risk factors for FND? Or do they arise as a result of having chronic symptoms? And most patients that we included did have quite chronic symptoms. And of course, also the specificity of the findings. Are these just something we see in FND, or are they seen in other sort of related disorders? And there are clues, or there are avenues that we can use from these results to kind of think about future research, particularly as we know that cortical surface area and thickness are sort of orthogonal components. which cortical surface area being a better representation of kind of underlying volume, whereas cortical thickness is more affected by kind of volume loss through life. We are planning to do some further granular analysis, including receptor density mapping, so mapping on the morphometric changes that we see to kind of normative maps of neurotransmitters to see whether or not, neuroreceptors, to see whether or not the changes that we see in the structural scans are related to particular regions that express certain receptors. And also we feel that the results and the analysis of this project suggests that agreed minimum clinical variable data set for kind of future imaging research in FND is required. So just a very short subliminal slide, so quick you won't see it because it's not really related to this, but I am doing a psilocybin for FND project as part of my PhD. If you're interested, please speak to me. I absolutely love talking about it. Or you can direct yourself or your patients to our website, scifund.co.uk. So that just leaves me to acknowledgement and thanks. So I want to acknowledge everyone who's contributed to the project, with a particular mention for David Perez and Salma Ibeck, who've been really kind of helpful in steering the project. Thanks to Miriam, thanks to Professor Meta, and thanks to Tim, who is my supervisor. And Tim, incidentally, has about 2 years ago set me a challenge to try and shoehorn a reference to my football club in every talk that I do. I find it quite difficult to do so in this case. So last week, instead of contributing to the sum total of human knowledge, I was thinking about what it would be like if our current home kit was sponsored by the BNPA. And it is to the BNPA that I'd like to say my final thanks for giving me the Lishman Prize and for everyone for listening. I'm very happy to take any questions. Thank you.
Thank you very much for that. First question down the front here.
Hiya, it was a great talk, thank you. I'm from a different city with a better football team, or the red side of the team. So how can you convince me, as a lay psychiatrist, that you've got all these studies from all these different places, different T-size magnets, multiple sites, 2 different software programs, different analysis that you've gone through, threshold and maybe, I don't know whether you did what we did that. So how can you convince me what's going on biologically here with these 2 sites, the subcallosal sites and the cortical thickness? How can you convince me? What's the take-home message? Have 2 other studies ever matched those kind of findings? It strikes me a little bit like schizophrenia imaging research.
Yeah. I mean, of course, any neuroimaging study is never the final word on the sort of biological basis of a disease. I think, particularly when you think about structural imaging, I mean, I think it's a fair enough question of, so what, this is different, what does it necessarily mean? Is it just an artifact? I think to try and convince you of the robustness of the findings, I think we were pretty stringent in terms of the way that we harmonise the data, the way that we sort of corrected for multiple comparisons. And obviously also this is quite a large sample size, although, recent papers suggesting that actually you need thousands of people to make any conclusions about anything neuroimaging. As to the biological significance of these findings, I don't think we can say anything for certain at all. I think the regions that came out from the analysis they didn't surprise me necessarily. There were regions that had previously been talked about in the literature. Whether or not that's because some of the scans were also in this analysis as well, I don't know. But I think there's much more work that can be done. We hardly know anything about the kind of pathophysiology of FND in terms of at the brain level. So, I think I think we've got a lot more to do before we make any conclusions.
Thank you. I realised that was a horrible question.
Question at the front here, Narinder.
Thanks very much for a very interesting talk. Just a couple of questions. First of all, were the 2 groups, your controls and your patients, were they matched for things like educational level and psychiatric history? And secondly, some studies have implicated the amygdala in reduced volume, and did you find there was no difference in the size of the the amygdala?
Yeah, thank you for your questions. So on the first one, so they were age and sex matched, but there was no other variable that we could pick out for the whole group in order to match them for. So some groups had information about, for example, level of education, psychiatric comorbidity. As you saw with the slide about the clinical variables, we were only able to get depression history dichotomized for 60% of the sample. And in many cases, the control group lacked that information too, so we just weren't able to do so. Obviously, would have loved to have done so. The second question was about amygdala. Actually, when I woke up this morning, I thought someone was going to ask me about the amygdala. Yeah, it just wasn't significant in the results that we did. I think perhaps, if we'd had a larger functional seizure group, maybe it would be, but yeah, it wasn't in our case.
Final quick question, perhaps?
Sorry, I have a mic. I'm over here, actually.
Oh, apologies.
Mind if I just, sorry.
So apologies, the final quick question is going to go over here.
Congratulations on the Lishman Prize, Matt.
Thank you.
Great presentation. Along those kind of lines, what about comorbid neurological disorders or previous brain injuries, epilepsy, things like this? Did you look at the effect of those in your study?
Yeah, again, I can't sort of quote you on specific data, but these were all samples from research groups who compared, I don't want to say pure FND, but FND without sort of neurological comorbidities versus controls. There may be that there were some in there, of course, but we didn't have the data to be able to make any sort of decision on that. We'd have to go back to the original papers, I suppose, to see what, if there's anything that's sort of creeped in. But I don't suspect that it was a large proportion of the patients, if it was there at all.
Fantastic. I wonder if we could just thank and congratulate Matt once again before moving on to the